Good morning. My name is Aaron Whiteman. I'm a nephrologist here at Seattle Children's and a member of the Truman Katz Center for Pediatric Bioethics. I'd like to welcome you all to another Bioethics Grand Rounds. Before we get started, I'd like to say a few words about the format of Ethics Grand Rounds. Ethics Grand Rounds is meant to be a case-based consideration of an ethical issue in pediatrics. The cases presented are based on actual events, but are modified and intended to be a starting point for considering the issues raised. The case is presented by a children's clinician, today Dr. Patrick Javid, who I will introduce shortly. The presentation will last for 10 to 15 minutes. This is followed by a discussion of the issues raised at the end of the case by our invited commentator, Dr. Schwarzy. The remainder of our time will be devoted to discussion. There are microphones in place in both aisles, and I encourage all of you to come to a microphone and offer a comment or a question to add to our discussion. I'd also like to acknowledge Jeff Sconiers and Deborah Godfrey, whose generous gift has made these sessions possible. And finally, July 22nd is our 12th annual now, I believe, Pediatric Bioethics Conference, to be held July 22nd to July 24th. Our topic this year is Autism Reexamined, Ethical Challenges in Care, Support, Research, and Inclusion. So our case presenter and first speaker today will be Dr. Patrick Javid from Pediatric Surgery. Dr. Javid is an associate professor in the Division of Pediatric General and Thoracic Surgery at the University of Washington School of Medicine and a pediatric surgeon here at Seattle Children's. He maintains a clinical and academic interest in pediatric intestinal failure. Our commentator today is Dr. Gretchen Schwarzy. Dr. Schwarzy is an associate professor in the departments of surgery and medical history and bioethics at the University of Wisconsin School of Medicine and Public Health and a vascular surgeon at UW Health. That's the other UW. The focus of Dr. Schwarzy's scholarship has been on understanding and improving patient-provider communication in the setting of high-risk or high-uncertainty decision-making, and we're lucky to have her here to share some of her expertise with us in pediatrics. So with that, I will hand things over to Dr. Javid.
Good morning. I'm going to present our clinical case, and we chose a case that is very real life, and this is an example of a type of case that we see in the NICU as surgeons and as neonatologists several times a year. So this is a very real case for us. So the scenario starts in the NICU, and we'll be talking about baby X. She's a 10-day-old, 650-gram, 25-week gestation baby girl. In the NICU, she rapidly develops abdominal distension and abdominal discoloration that's concerning for an intra-abdominal perforation. We obtain a plain film which reveals both portal venous gas and a large amount of pneumoperitoneum or free air, indicating an intestinal perforation. Of note, a couple of days prior, she had a cranial ultrasound that revealed bilateral grade 3 intraventricular hemorrhage. So given the indications for surgery, we take baby X to the operating room emergently for an exploratory laparotomy. And in the operating room, we confirm the diagnosis of necrotizing enterocolitis with a perforation. The majority of her small bowel and colon are involved and are severely ischemic or necrotic. We find that only 10 centimeters of the very proximal jejunum, beginning at the ligament of Treitz, and the rectum are viable. The remaining small bowel and the colon are not considered viable at that time. The bowel is left in place at that time. We perform a temporary abdominal closure, and we get the baby back to the NICU for further stabilization. Now, at this point, the pediatric surgeon and the neonatologist meet together with the family, and this is a routine event for us to discuss the next steps in this baby's management. And really, the options include aggressive treatment with medical and surgical therapy, which would start with a second look laparotomy, usually the following day in the operating room, bowel resection, and so on, or the option of transition to comfort care for the baby. In the discussion with the family, in terms of discussing both the surgical option and the option of comfort care, we look at both short-term and long-term ramifications of the surgical option. So in the short term, we would plan on resecting all of the involved bowel probably the following day at the second look laparotomy. We would perform a temporary ostomy, which would be eventually closed, and she would get an anastomosis between her proximal jejunum and her rectum, so not a lot of bowel. She'd be on antibiotics and would be on bowel arrest for a while and would be started on parenteral nutrition if she wasn't already on it. She'd have a long stay in the neonatal ICU and the patient ward, And there would still be the possibility in the short term of sepsis, worsening abdominal infection, or worsening head bleeds that could lead to death. In the long term, we would expect, if this baby survived the acute critical illness course in the NICU, we would expect survival into school age. She would be on long-term parenteral nutrition that would be slowly weaned over many years. The family should expect multiple admissions for line infections, line placements, and there may definitely be further indications for abdominal surgery, intestinal reconstruction in the years to come. And the baby may need a G-tube, may likely need a G-tube for some or all of her enteral nutrition. The baby would be seen weekly initially in our intestinal rehabilitation clinic, which has become busier and busier every year, and this would eventually transition to monthly visits. So they would be frequent visitors to our hospital. Given the length of bowel, she may ultimately require intestinal transplantation at an older age. And given the prematurity, the critical illness, and the IVH, there's definitely the possibility of cognitive and motor delay in the long term. The option of comfort care was also discussed with the family. The baby would be gently sedated for comfort. No further surgery would be offered. The family would be able to hold the baby at the bedside, and the baby would be extubated and pass away, die in the presence of her family at a reasonable time of the family's choosing, so that family can be present. And one of the reasons we bring this case up is that our long-term prognosis in pediatric intestinal failure has changed dramatically over the last 10 to 15 years. If you went back a couple of decades, a baby like this would not have a very favorable prognosis because of the limited options for bowel rehabilitation and because of the extent of liver disease, which was often the cause of early mortality. But multiple changes, including safer delivery of parenteral nutrition, better prevention and treatment of sepsis, including line infections, new, simpler operative techniques for bowel lengthening, and multidisciplinary intestinal rehabilitation programs have really served to improve the survival and the prognosis of these children. So again, we would expect a baby like this that makes it out of the NICU to survive long term, but at a significant cost of healthcare utilization for the patient and family. So the question we'll be talking about today is from an ethical framework: how can we communicate prognostic uncertainty while informing and empowering these parents to make decisions about their critically ill newborn? And it's a pleasure for me to turn the podium over to Dr. Schwarzy.
I usually use the lavalier, so I think I'm going to try and do that because I kind of jump around a little bit. But let me know how this works. That over there. Is this okay? All right, kind of a high squeaky voice, so I want to make sure it's all right. And then just bring up my slides here. So it's just a complete pleasure to be here, but I have to tell you it's also really intimidating. As a vascular surgeon, the average age of my patients is about 80, and I know almost nothing about pediatrics. I did do a rotation in pediatric surgery for about 3 months as a resident, but that was a really long time ago. The reason I'm here is because Erin suggested to me that the work that I've been doing with frail older patients who have acute surgical problems at the end of life actually has some really important analogies with the kinds of patients that Patrick just described and many of the other decisions that you need to make for these very sick children who have really long-term chronic illnesses. And so I'm here because I trust Aaron and because I think he's really smart, but I'm also here to learn a little bit more from you, knowing that I am an old person's doctor and I don't really have a great sense about how this might work in children. So I'm going to start by orienting you to what I'm going to talk about within a clinical scenario that is familiar to me, so I can try to explain the bioethical elements that you can then attach pieces to as we move forward. So as I'm talking about this frail older person, it will be helpful to think through the analogies with your own patients as well. So I'm going to start with a story, and this is of an actual patient that one of my partners treated about 2 years ago. She was a 79-year-old woman who had pretty bad end-stage lung disease called COPD and was at home on oxygen. she also had chronic renal insufficiency with an estimated GFR of about 20 or so, and some pretty bad arthritis. She needed a walker to get around. And the main reason she was still at home is because she had really fantastic family support, and she was really sort of just barely making it at home. So unfortunately, she came to our hospital with what we call a tender thoracoabdominal aneurysm. So this is an enlargement of her aorta from just distal to the subclavian artery all the way into her abdomen. And it was fairly clear that although the aneurysm had not ruptured, it was likely to do so given the pain that she was having. And this is a pretty big deal operation. The surgeon very appropriately sat down and talked to her about the risks of surgery. He said, you know, with surgery, I think you have about a 50% chance of survival. I think even with surgery, you have probably an 80% chance of being on a ventilator long term because of your chronic lung disease. And I think you have a 60% chance of needing dialysis long term, given that your kidneys aren't doing all that well and surgery is pretty rough on them. He also very appropriately offered an alternative of palliative care, given the high risk and the high stakes of this operation. And she and her family had some time, and she wasn't sort of in extremis, and they sat and thought about it for several hours and ultimately decided that she wanted to have surgery. So the following day, they took her to the operating room, and they made an incision from here all the way down to her pubis and did a 6-hour operation, which for the most part went pretty well. She got multiple blood transfusions. It was a difficult operation for sure. The next day, she was in the ICU, and you can imagine what she looked like. She was on a ventilator. There were probably tons of drips running behind her. She was very, very edematous. And the surgeons came by to see her in the morning and thought, wow, this is as good as we had hoped for. She's making a little urine. She was holding her own. She didn't need a lot of blood. A few hours later, her family came by and took one look at her, edematous, with tubes, unable to communicate with her, and said no, she would not have wanted this. And they turned around and they asked the team to withdraw all life-supporting treatments. This was not acceptable to them, and it certainly wasn't acceptable to her. So if I had to describe in one word what went wrong, what happened here, I would say that the patient received unwanted care. And I think it's certainly in the older population, but I suspect this exists in some of the places where you live as well, that there's more attention to this unwanted treatment at the end of life. A lot of technology going into people right before they die. And there's a real public outcry about what are we doing and why aren't we doing a better job making these decisions around the end of life. So if I had to describe where this problem came from, I would say that there are two things. And the first is what I would call a mental model of how we think about medical care. And Joanne Lynn and David DeGrazia wrote this brilliant paper in 1991, which they called the fix-it model. It's actually not called that, but they were describing this mental model. And they said most people, when they think about healthcare, they think about people who are normal and healthy, and then you get sick, which is an aberration from being normal and healthy. And then medical treatment reverses that. It fixes your problem, and then you return to normal. And Lynn and DeGrazia very appropriately say, well, that works for some things. Sure, it's great for appendectomy, for appendicitis, penicillin for strep throat. But it really doesn't capture the issues that go on when we're talking about chronic illness and long-term disability and survival. And as such, this model can really trip people up, and they fail to make the decisions that are appropriate because they think that medical treatment is going to fix the problem and make them normal. I have to tell you, there are two completely brilliant papers by William Silverman, who, as I understand it, was a neonatologist, which I've noted down here. And he read this paper by Lynn and DeGrazia and said, yeah, this is what's going on in my NICU, and we really need to think about this. I think this model is very pervasive, and once you start thinking about this idea of fix it and remedy for the problem, you notice it everywhere. If you haven't seen this YouTube video, it is absolutely worth Googling because it is completely hysterical. This is called, if you Google orthopedics versus anesthesia, you will get this little Animoto video, which are these two bears who are talking about a fracture. So the guy in the stripes is the orthopedic surgeon, and he says, I have a fracture, I need to fix it. He's talking to the anesthesiologist trying to get a room in the OR. And she says, well, where is the fracture? And he says, it's in the emergency room. And it goes on, back and forth, and back and forth, and the anesthesiologist is trying very desperately to draw out some information about the patient and not the fracture in order to try and figure out what to do for the patient. And ultimately, it comes up that the orthopedic surgeon says, well, she has something I have never seen before, asystole. So the anesthesiologist at that point flips out saying, well, your patient is dead. And I do think, the reason this is funny is because it reflects some level of reality that is actually something that we need to think about. And this is what Silverman says. He says, these decisions aren't about just fixing the problem. What is at stake is embedded in the question about ends. How well and how long will this baby live? And not the means-defined question. What is the diagnosis, and can this disorder be corrected? So to the degree that we compartmentalize these problems into little pieces that then we can fix, we do the family and our patients a great disservice by oversimplifying the model at which we use to try and make a decision for them. I have to tell you, I think this is the other source of the problem, and I quite frankly blame the bioethicists, but please don't tell Ben Wilfond. While I do think informed consent came at a time where it was greatly needed, it's really not a tool that works all that well for making decisions. It comes from the best of places to try and honor autonomy, and yet it's clunky, and it doesn't do a particularly good job at helping people make decisions. So you can imagine how my patient and her family went through this, right? If she had a 60% chance of having kidney failure, she had a 40% chance of not having kidney failure. If she had an 80% chance of being on the vent long term, she had a 20% chance of not being on the ventilator long term. And if she had a 50% chance of death, well, then she had a 50% chance of not dying. And she went down the numbers and said 40, 20, 50, and said, wow, I have at least a 20% chance of being exactly like I was before surgery, when that was never in the cards. Informed consent did not help her get to a decision that was aligned with her preferences. And while we have been awesome at innovating the technological things that we can do for people, we've done nothing to innovate informed consent and how we make decisions with people over the last 50 years. And we're still using this same clunky mechanism to help people decide about whether to have surgery based on a court decision in the 1970s. So our research group has worked very hard to try and innovate this process, and I'm going to talk a little bit about our innovation here. So our intervention is called Best Case, Worst Case, and it's really two things. The first is a graphic aid, and this is kind of a picture of what the graphic aid looks like. It's a graphic aid that you can write on a simple pen and, simple pen and paper diagram. There's not anything particularly complicated. And you can see it shows that there are two treatment alternatives, first surgery or supportive care. And I've made this graphic aid and labeled it to go with the patient I just described. Each line represents a range of possible outcomes for the treatment, with the star representing the best case outcome and the box representing the worst case outcome. And then there's some notion of probability about what is most likely to happen that's marked on the line in between. The second part of this intervention, or this tool for decision making, is about how you talk about the best case outcome and the worst case outcome. And the idea is to use narrative or storytelling to describe what it might look like to have each of these interventions. So if I were to describe the best case outcome for our patient, I would say, in the best case scenario, we would go to the operating room. We would have a long operation, about 6 to 10 hours. Afterwards, you would be very sick. Even if everything went well, I think you're going to need to be in the ICU and on a ventilator, probably for a week, maybe even longer than that. But if we're really lucky and you don't have any complications and your kidneys hang in there, I think we could get you up to the floor afterwards. And then after maybe a week or so in the hospital where you regain your strength and you work with physical therapy, I think maybe we can get you to a nursing home. But given that you were just barely making it at home, given that you have pretty bad underlying lung disease and your kidneys aren't so great and your arthritis is pretty lousy, I don't see you getting home. I really think that you are going to need the kind of care that is going to require that you are in a nursing home for the rest of your life. And given the amount of chronic illness you have, I don't know how long that is, but I don't think it's a long, long time. And then I would describe the worst case scenario. And I have to tell you, the worst case scenario is not dying in the operating room. For me, the surgeon, that is the worst case scenario. But I'll be honest with you, when we did focus group with seniors, dying in the operating room is actually a really great outcome for them. It's painless, it shows an intent to live, and on top of that, you don't have to make a decision about your own death. That is left to someone else who they described as the surgeon and or God. But nonetheless, that doesn't happen. You know, I've been a surgeon for 20 years and the number of intraoperative deaths I've seen is like 4. And most of those people had traumatic injury. So the worst case scenario is actually worse than that, right? The worst case scenario is that she has this operation and goes to the intensive care unit and then has a series of complications that get sort of worse and worse and require more interventions and more treatments. And ultimately, 3 weeks after surgery, the family decides to withdraw life-supporting treatments. And so now once the surgeon has told a story that describes the ends of what is possible, the surgeon uses his or her knowledge about what they know about the patient, about what they know about this operation, and says, what I think is most likely to happen, and then tells a story about how that would look, incorporating not just the immediate short-term outcomes, but also a longer-term story about what it would look like for the patient. And then analogously, the same thing is done for supportive care. So this is not to suggest that we want to replace informed consent, but rather separate shared decision-making from informed consent. And the idea behind our intervention is to provide a platform where you talk, and a framework where you talk about possible outcomes with patients and families so that then they can talk to you about what's important to them. And so the best case, worst case tool is presented up front to describe the choices and the possible outcomes, followed by elicitation of their goals and their fears, and then the surgeon is supposed to provide a recommendation. Once the recommendation has been made about potentially going to surgery, then informed consent would occur. So why would you believe some random surgeon from Madison, Wisconsin, who just shows you this tool? So I wanted to bring a little data because I know people are very interested in data. It's not a ton of data, but I have to tell you that we have taught surgeons at Madison, Wisconsin to use this tool, and in many ways that this was a success. This was a study funded by the Institute for Aging, and it was just a simple pre-post control study. We trained 25 surgeons, cardiothoracic, vascular, and acute care general surgeons, all to use the best case, worst case tool in the setting of a frail elderly patient who had been admitted to the hospital with an urgent but not emergent surgical problem. After we taught them, we enrolled 20 patients into the study where we audio recorded surgeons having this conversation with the patient, retained the graphic aid to analyze it, and then interviewed patients and families about a month to 2 months later about their experience. So what are our results? So thank God the surgeons can actually do this, and to be honest, we would be completely dead in the water if they couldn't do this. But in the background, I can show this is a graphic aid that one of my partners wrote for a 90-year-old gentleman who came in with forefoot sepsis, meaning that he had terrible gangrene. And the choices he offered were surgery, which was amputation, versus home hospice. And you can see what he said about best case. He said, well, you would be alive, but you would have a below-knee amputation, that you'd probably be in the hospital for one week, but the life expectancy was really probably not more than a year, and that he would really never be able to go home again. And then you can see sort of what he wrote for best case with hospice on the other side. I have to say the audio recording is from a different patient, and this is probably my proudest moment in research, which is this surgeon had taught to a frail elderly lady who came in with a really bad problem with her colon that at this point I don't understand as a vascular surgeon. But the surgical treatment recommended or surgical treatment that was on the table was a total colectomy. And after explaining mostly to her family, because she was quite delirious, the options, and then listening to the family about what was important to her, he said, this is what I know about her. She didn't want a lot of these interventions, and we're going to do a maximum amount of these things if we decide to go for surgery. So my general thought is that surgery where she ends up in a nursing home with complications from surgery is not something that she ever wanted. And I think really this is the goal of this intervention, right, is to provide a treatment recommendation that is distinctly and clearly attached to patients' values and goals and preferences. So what else did we study? So one thing we used to measure improvements or measure what we did with our tool is the score called option 5. So this is a direct observation of the conversations looking at patient engagement. And we certainly saw an improvement in the median option score between our pre-group and our post-intervention group. It went from about 41 to just over 70. But really where we saw major improvements was in our qualitative analysis of these conversations. And what best case, worst case did was literally change the way the conversation proceeded. So in our control conversations, the problem, when the surgeon was explaining what the problem was to patients, was distinctly linked to an operation. And that operation had some promise of fixing the problem. So here's a cardiac surgeon saying, it's the aortic valve, it's getting smaller. To take care of this problem, we either need to change the valve or put another valve in. Just very specific fix-it language. And then in our post-intervention conversations, the surgeons really started off by saying, this is a choice. This is a choice we have to make, and both alternatives are valid. And as one of our surgeons said, so we kind of have to decide which of these paths to take, and a lot of that depends on your sense of where you've been in the last year. The other thing was a change in the description of treatment outcomes. And in compliance with informed consent, there was a lot of statistics about what the outcomes were. So one surgeon said, the risk of reintubation is probably, about 7 to 8%, which on some levels is informative, but it doesn't do much to allow patients and families to imagine what it would be like if the patient got reintubated and what the consequences of that would be. Whereas after the surgeons were taught to use our tool, there's a much larger focus on outcomes. Under the best of circumstances, that would involve being in the hospital for probably a week or maybe 2 weeks. And because of your age and your heart problems, part of that might be involved being in the intensive care unit. We had a real description about how a patient and their family might experience what it would be like if these things were to occur. And then finally, we saw a very different sort of form of deliberation about treatment options. And I think when you think about shared decision making, what you're really trying to get people to do is to deliberate out loud in front of you as the physician so that you can hear what's valuable to them and then work with them to attach a treatment to what they have told you is valuable to them. Before our intervention, that really sort of progressed towards this justification about surgery based either on tests or clinical exam findings. After the intervention, there was really much more attempt to try and elicit preferences from patients and families. Different people in this moment could feel differently about that. How do you feel about that? That's the kind of conversation we were hoping to get. When we went to interview patients and families, and I have to tell you, many of the patients in this study died, so we were often there with family members asking them what happened. The other thing is, if you are old and cognitively intact, it takes like very small amounts of infection or other acute illness to tip you over the edge into delirium or cognitive dysfunction. And so many of the older patients who survived, we went to interview them and they had no idea what had happened to them. So we really relied on their family members to tell us how this conversation went down. But they actually love best case, worst case. Some families, we went to their house and without prompting from us would pull the graphic aid out of a drawer and say, the surgeon used this and it was really helpful to me. But they were clear about how it helped them. It showed that there was an actual choice to be made, not surgery with lesser alternatives. And they thought it helped facilitate dialogue and understanding. The place where we saw the most impact, though, was really this idea about setting expectations. And people would say, wow, we were really hoping for a best case, but we were grateful that we knew what to expect if things didn't go the way we wanted. And that allowed us to prepare. And I think that at the very least, is sort of the something that best case, worst case can do, that when we use things like risks of heart attack, risks of stroke, risks of X, Y, and Z, doesn't inform them in the same kind of way. There's this awesome anthropologist named Sharon Kaufman, and she's studied a lot of people sort of dying in the hospital. And she says, patients, they don't need more information. They need more interpretation of the information that we're providing. And I think that's how this works. So, sadly, like with all research, there are some real issues. And I showed you the good stuff, so now I should probably tell you the issues here. So it's really hard to train surgeons. We worked very hard to schedule a 2-hour one-on-one session with surgeons at a time of their convenience. And of the 25 surgeons, about 15 showed up mostly on time for their scheduled appointment. The remaining 10, not only did they cancel once, but they canceled like 5 times. And I totally get this as a surgeon, right? Something comes up, you've got to get this case on, and you look on your schedule and you say, oh, well, there's that training thing, I could probably cut that out. So it's resource intensive, and to have the surgeon bail at the last minute is expensive. So, and it's also sort of hard to know how, it does actually, it seems easy, and lots of people are like, I already do that. And you're like, well, I know you don't already do that. But it's a real change in how you talk, and it does require practice with standardized patients. So this issue about how long and how to get this done is a serious issue, particularly when you think about scalability. We also noticed that there was this huge failure on the surgeon's part to break bad news. And I think that this is something that hadn't occurred to me before, but what happens is they start by saying, we have a choice. And the problem with saying we have a choice and one of the options is palliative care is that that's very disorienting to patients and families. They have not understood why this is such a tough choice. And without a clear shot across the bow, broadcast that this is a bad problem and it is unlikely to end well whether we do surgery or whether we choose to have palliative care, really makes it hard to orient them about what this choice is about. And so now in our version 2.0 training, we work really hard about breaking bad news. For anybody who's tried to do research in a palliative care setting or end-of-life setting, it's really hard to enroll patients in a study like this. They are scared, they are sick. The hospital moves at a very, very rapid pace. And even though you hire the nicest, most polite, charming research assistants, they're just too overwhelmed by the pace of the hospital to participate. One of the patients actually was a 90-year-old woman who came in with a thoracoabdominal aneurysm, and she got the little brochure that we made to go with our study, and she goes, oh, Dr. Schwartzy, I know Dr. Schwartzy. He came to our nursing home and gave this awesome talk, and my research assistant got like, oh, yay, we're going to be able to enroll her. And she said, do you want to enroll? And she said, oh, no, that's way too overwhelming. So it's really hard to do this research. And the people in our study are probably, there's some selection bias based a lot on the fact that people really struggle to consent to be in a study like this when they're sick. We found that even though we had given surgeons phrases to encourage deliberation, things like, what do you think about this? If your father could talk to us, what would he say about being on a ventilator long term? It's actually harder to elicit preferences than that. And often what we heard was the surgeon would elicit preferences using those phrases that we had taught them, very, very nicely done. And then the patient's family would say, well, we just want her to live as long as possible. And the surgeon would be like, okay, let's do surgery. And there was no discussion about what does that mean, live as long as possible? What does that look like to you? What's important? And so we've tried to modify the tool by writing on the bottom of the graphic aid, what's important to you now? Because I don't think we can teach surgeons to do everything here. I think we're just going to be stuck with teaching them the framework. But I do think people hold on to this graphic aid and really do use it to deliberate. And so by leaving the phrase, what's important to you now, on the bottom of the graphic aid, I think there is an opportunity for them to start thinking about values and goals. This issue about hesitating to make a recommendation is a real bugaboo, and I think that, again, this is a failure on the part of the bioethicists, and I think it comes out of this genuine place of really wanting to respect patient autonomy. But even with our standardized patients where we had coaches helping the surgeons get through these scenarios, the coach would say, are you ready to make a recommendation? The surgeon would be like, oh no, I don't do that. My job is to put the choices on the table, their job is to choose. And if you ask me, I think that's a real failure. Right? That is abandoning patients to their own autonomy, and it fails to actually help them match what you know as a physician or care provider who has strong information with what they know about their values and goals and assist them in making the decision. Respecting autonomy does not require saying just choose off the menu. Respecting autonomy says, given what I know about you, this is what I think we should do. And I found that was very hard to convince surgeons that that was okay. This issue about who defines choice. So we left this up to the surgeon for multiple different research design reasons. But I have to say that when the surgeon defines the choices are potentially limited by the surgeon. So for example, one of our cardiac surgeons said, well, your choice is to stay in the hospital and have surgery on Monday, or to go home and have surgery on Monday. So I think that this idea about who defines choice is a really critical idea, and is something that we as clinicians need to think about when we think about honoring autonomy. And I think that this is probably even harder in pediatrics when you're really thinking about things like the best interest standard and how we make choices. How do we measure whether this is better? So that is a huge problem also in palliative care research, and I think that it's something that people who do a lot of decision science really have failed to tackle well. I have to tell you, the literature makes it look like this decisional conflict scale is just the bomb, and this is actually the way to go. And so the idea is that if you are making a good decision, then after the decision you will have less conflict about what the decision was that you made, and you will have less decisional regret. I have to tell you that as a surgeon, I can make sure that you will have no decisional conflict, because I can say, if you don't have this surgery, you will die, and you will have no decisional conflict. But that doesn't mean you are more informed. And I think the problem with these patients is that there's a lot of cognitive dissonance here, and it's really hard to express conflict or regret, particularly about a major decision like surgery. And then finally, what is a good choice? I mean, that's a real value judgment. For some people, that was surgery, and for some people, that was palliative care or some other treatment that wasn't surgical. And I don't know how to determine that before we start. And I think that you could do a study where you made a determination before you started the study that it's better to have palliative care, it's better to have more surgery or less surgery. But I'm not entirely sure that that's okay, because that is a real value judgment, and it's not clear that the researcher or the group as a whole should make those judgments. So I'm a little conflicted about how to evaluate this further than what I've shown you. So with that said, I want to transition into this case and think through a little bit about how we could talk to these parents about what to do for baby X. And Patrick and Aaron said that they would help me. So we're now thinking about this conversation between the neonatologist and the baby's family and the surgeon. And the options are aggressive medical and surgical therapy and transition to comfort care. So what's step number one? I'm afraid this is bad news. And I think that makes a lot of sense, right? The fact that most of the bowel is infarcted is bad news, because regardless of what we decide to do, it's not going to end well. It's not going to end the way the family is expecting it to end. The possibility of what they wanted for this baby has dramatically changed with this acute event. And without some shot across the bowel, I think it's likely that they are going to miss that point. So I have bad news. I have to tell you, the drawings that I'm going to show in the next several slides are from a whiteboard video that you can find on YouTube. And the reason we made this whiteboard video is to be very clear about what best case, worst case is. The case that we describe is a case of Mr. Lombardino, who is 85 and demented and has toxic megacolon. I have to say, as I went through the pictures and put them on these slides, if you just put a little baby in an incubator up there, it actually works all right. So just try to imagine that it's not Mr. Lombardino, but baby X in the picture. So then the next step is really to draw the graphic aid, and it's certainly something you can do on the fly, and I've done it a few times in clinic on the fly, but it's actually pretty hard to do that ahead of time and until you're really facile with the tool. And so when I'm really sort of thinking through what this is going to be like, I like to prepare my graphic aid before I go in and talk to the patient family, because then I can just refer to it. At times, I will suddenly need to use best case, worst case when I haven't prepared for it. And I think one of the things that you can do is just draw the lines and the stars in the box. And then after you've had this conversation where you've described using a story what the outcomes are, you can write little things next to it. When we did some focus groups about best case, worst case with seniors, they didn't like the paper with just the stars and the boxes and the circles. They felt that that just didn't allow them to think through it later on. And they really wanted some little jotting down of what some of these outcomes would, so that it would allow them to think through that later. So the diagram is simple, but what's not simple is writing little bits about what those outcomes look like, and that takes a little bit of time. All right, so here's the trouble for me as the vascular surgeon. Tell a story. So what does it look like for baby X to have surgery? In the best case scenario, Patrick would take her to the operating room. The next day, pretty soon, And the surgery would probably take about 2 hours or so, where they would remove most of her bowel, or at least all the bowel that is dead. And then she would come back to the NICU. And she might even need another surgery after that, or an ostomy, but she's going to at least need 1, if not 2 surgeries. She would still, given that she's 25 weeks and has an intraventricular hemorrhage, then she would be in the NICU, actually for quite some time, on a ventilator. And she would start to receive food via an IV line, and she would need surgery to have that go in. And so probably after about 3 or 4 months in the NICU, if everything went really, really well, she could get out of the NICU and go to the pediatric surgery wards, where she'd probably need some oxygen. She'd still have to have all of her food via the IV line. Maybe we could put a little stuff into her G-tube. And then ultimately, if everything went really well and she didn't have any more complications after about 4 or 5 months, maybe we could have her go home. But she'd need a lot of support at home. She would have a central line. She would have TPN that would need to be changed every day by the family. She'd probably need some care for her G-tube. And we could expect, even if everything goes well, in the best case scenario, that she will need to come back to the hospital. She'll need to come back for the bowel rehabilitation clinic, and she will need to probably come in for things like infections for her central line, failures with the G-tube. If we are lucky, she might get to school age and start to be able to take more feeding through the G-tube. And I think it's really important to explain what that feeding is like. This is not her, eating cake at age 1. Maybe it is at age 6, but we have to describe a story that's realistic in the early term. And then describe a story about in the long term. If we're lucky and everything goes well and she doesn't have any major complications and her intestines start to hypertrophy, get better? Adapt. Oh, they adapt. And her intestines get better in some way. She may not need the IV feeding at age 5 or 6. And if we are lucky and the brain hemorrhage and she doesn't have any other complications, maybe at age 5 or 6 she could go to school and play and learn with other children. And maybe at some point, in the best case scenario, she wouldn't need all of these things. Does that sound about right? Right. And then describe the worst case scenario, which is probably pretty lousy, but it's not dying in the operating room. It's a surgery to remove the dead bowel, maybe another surgery because there's more dead bowel, and then a series of complications, one on top of the other. So weeks on end in the NICU where things start to build up, and ultimately we decide that really what's going to be possible for her is just not okay. And we decide to stop doing all of these treatments to support her life and keep her comfortable. And then what is most likely? Well, it's probably somewhere in between, because best case scenario is certainly possible, but that requires a lot of things to not happen, like a lot of complications to not happen, and then the bowel needs to adapt. And so what is most likely for her? And it's probably a much longer course, and most likely also some, in the long term, thinking about the chronic illnesses that she and her family are going to be faced with. Maybe some cognitive deficits from her intraventricular hemorrhage, likely some real issues with nutrition and how to sustain her, and potentially even something like a small bowel transplant. And then you can talk about comfort care. What would that look like? And as Patrick had described before, in the best case scenario, we remove her from these things. We give her a little bit of medicine, morphine, or something to keep her comfortable. And the family comes in and they have time to gather, and they sing to her, and they talk to her, they hold her and comfort her. And they have some time to say their goodbyes. In the worst case scenario, they just don't have that much time. They remove her from the life support and she dies very quickly. I find that the comfort care side is hard for me as a surgeon because I don't have a great sense of sort of the range of palliative care outcomes, but I think this is an opportunity to get some help from the palliative care physicians. I have a neurosurgery friend who likes to call palliative care in to help with this part, but please don't say Dr. Campbell is here now to tell you what doing nothing looks like, because that doesn't work out so much. But I do think that this is a real opportunity for collaboration with other people to try and really generate the stories about these outcomes that will assist patients and families. So it's really important that the worst case scenario is not described as death, or that it's acknowledged that worst case scenario is not dying in the operating room. Worst case scenario is much more drawn out than that, because people will make assumptions that the worst case scenario is that she could die, and that death in their mind, unless you clarify this, will happen in the operating room, and that will be very peaceful for them. It's not happy, but it is much easier than what the worst case scenario actually looks like. So then this issue about eliciting preferences, and I think that this is challenging for everybody. We were not taught to do this in medical school, and I think using phrases like "how are you thinking about this" is really the way to draw out patients' values and goals. And then make a recommendation and really hear from them about what's important for them, what they are hoping for, and what kinds of things they fear for their child. And once you've heard those things, if you think that the things that they fear are really likely to happen with surgery, then the recommendation should probably be for comfort care. And that's the kind of work I think that we need to be doing, certainly as people who are talking to patients and families about treatments when the outcomes are less than ideal, when we're not fixing the problem. So here are the key elements. So we break bad news, use storytelling to try to describe these outcomes, elicit preferences, and make a recommendation. So hopefully we have enough time for questions, and I didn't bastardize the case too much, explaining best case, worst case. Jeannie, where'd Jeannie go? Oh yeah, Jeannie and I have been thinking a little bit about how to do this in the NICU, not necessarily when there's a surgical decision to be made, but just using it for prognostic reasons, and that may be something people want to describe as well. So as a surgeon and an ethicist, you'd think I'd have pretty tough skin. I actually don't. So while I'm really happy to have a great discussion, please just don't throw rocks at me. And then I just want to acknowledge my team. It's really hard to do research, and it takes a huge effort. So thank you very, very much for your attention.
I have two questions. One you and I have talked about before, and this issue of the point estimate, what's most likely on that continuum, and how it can be really difficult to, given the lack of data, et cetera, and the inherent difficulties for prognosticating. How do you recommend we do that best? And then secondly, maybe more importantly, how do you imagine the process going? Because as you said, this can be a collaborative discussion, and in this case, for instance, the surgeons have a lot to add to the discussion. The neonatologists have a lot to add, given IVH and what they know about just overall progress of the child. And so how, I mean, that really, I think, would necessitate a shift in how these discussions happen. Like, for instance, everybody in the room together, who owns the document and how is it revised over time?
Right. So those are great questions. So I think this issue of the point estimate is always something that really bothers people. And I think the issue is that it doesn't have to be super duper precise. And sometimes most likely is not actually in between best and worst. It's either best or it's worse. And that there just isn't a gradation in between. I think that most likely you could say is just like best case. I really think what's most likely to happen is what I told you in the best case scenario. And we need to know that there is a worst case scenario here as well. I think surgeons particularly are really interested in this idea of sort of precise risk estimation, and there's a fair amount of data to suggest that it doesn't need to be as precise as we think it does. And there's a lot of face validity to that. If I tell a patient in my office that you have a 18% chance of having myocardial infarction after surgery versus a 12% chance of myocardial infarction after surgery, it doesn't seem to me that I've actually told them anything that's going to be that useful or sway their decision. And so I really think it's about sort of dividing the line in half and thinking, is it more like worst or is it more like best? And then how close is it to best or worst based on what I understand about this patient and the comorbidities that aren't necessarily described in the study that I'm using to make these estimations. As far as this issue about collaboration, so I actually think that having a frame of reference with which to collaborate with other people could really improve continuity of care. And ideally, the person who sort of owns the document should be the patient and the family. And we certainly saw that in our study that the patients and families really like to hold on to the document. But you could imagine that once whoever the attending is, or so the primary care provider is, has used the framework to outline what is possible, that someone else could come in and use that same framework to add their input on it. And you wouldn't necessarily have to agree with it, but you need to use the framework in the same way. And so if you're the nephrologist and you come in and say, wow, that's what they told you for best case scenario, I have to tell you, I might have said best case was a little better than that. And you know why? I think the kidneys are a little bit better because I know these things that maybe they didn't include in their calculations. And I think to the degree that we communicate with families using the same kind of framework, the same kind of story building, it will allow them to not feel that the care is so disjointed, because what happens now is everybody comes in with a different story and a different, oh, your kidneys are doing great today, lungs not so good today. You know, it gets so disjointed. And I think, and I also think that this is like an awesome place for nursing and social workers to contribute, because then they can just work with the patient and family to say, you know, this is what the doctor had said, what best case looks like. Tell me a little bit more about that. I mean, I actually think that they're really good at these things, and as long as they can use the same kind of framework, that's less likely to confuse a family so much. Yeah. Seema.
So thanks for an excellent talk. And I think your approach seems like a huge improvement over what we have, but there are lots of interesting questions. And so I was thinking of three in particular. So very quickly. First, I was wondering about framing effects. So, you know, does it matter that you start with best case and then talk about worst case, and that you start with surgery and then talk about palliative care, and you've tested that? The second, I was wondering whether, when you think about pediatrics, if there's this challenge because parents are supposed to be thinking about best interests and they don't have any frame of reference about what this child would have wanted. Whereas with some of your patients, right, you have the sense of what the person, how they lived and what they wanted, what their values were. And relatedly, I think, is this problem with pediatrics where family interests have to count. Other siblings, the parents, all of that should count, but you know, how to balance those is really hard. And the last question is whether cost should be one of the things that's discussed, which I think is a controversial issue that many are focused on.
Yeah, I mean, those are all great questions, of course, all very challenging. So framing effects always matter. We haven't gone as far as to test framing effects, but certainly in our focus groups, we had some seniors say, well, why not talk about palliative care first? Why not talk about worst case scenario first? I think all of this is an empirical question, which could be answered with empirical data. I think right now what we're trying to do is just see if the framework is valuable to people. The second question was about family interest and the best interest standard. So this is, of course, where I struggle as an ethicist. I mean, I certainly do pediatric ethics consults, but I really like relying on my own patients' autonomy and things that we know about them. And so I think this best interest standard is really, really challenging. I do think by telling a story about sort of the chronic needs that are sort of expected to result as a decision, from a decision, particularly when it is so very hard to explain to somebody that the reality has completely changed after this diagnosis of dead bowel, really do allow people to start thinking about the impact, not just on the child, but also on the rest of the family and the rest of their lives, and how they would manage that and how put that all together. And then the last issue is this issue of cost. And you know, after the whole death panels thing, I've tried very hard to stay away from this issue of cost. And I think the way I like to conceptualize it the best, that makes the most sense to me ethically, is an issue of efficiency. That when we are providing treatment, regardless of how expensive that treatment is, that is not valuable to people, that doesn't end up with an outcome that is acceptable, then we are wasting things. And we are not using the resource for things that would be more valuable to them. And whether that's home care for elderly patients, whether that's better palliative care for children who are sick and have sort of a lifetime of disability looking for them, or even more disability care. You know, to the degree that we provide treatments that are unwanted and not valuable to them, that is a complete inefficiency thing. And I think rather than looking at bottom line costs, looking about how we spend the money is a way to think ethically about how to do this better without thinking, well, we have to rationalize costs. Yeah, please.
I just want to say on the family factors, the contextual factors of the in the situation are very, very important, and that's something that we talk about because, I mean, we always hear it, but the patient is the baby and the patient is the family, and this diagnosis long-term will have a huge impact on the family. And I remember one case that was similar to this, where we had, the family was literally like the Brady Bunch. They were, on a second marriage, and mom brought in 3 kids, and dad had 2 or 3 kids, and now, their question was, how is this going to affect our 6 other kids? Well, it's a huge impact compared to the family that's been trying for 10 years to have a baby, and this is their last chance. I mean, that's a totally different context.
Yeah.
So I think those, that's involved in the conversation in the NICU.
Absolutely.
But that means you have to get to know the family, which is really hard in this situation, right? It's like, it could be 2 in the morning on Saturday, and, you've known the family for a few minutes, so it's challenging.
Yeah.
Thank you all for a really great discussion. I'm not sure this mic is on, but I've got a pretty good voice.
I can't hear you.
Oh, that's right. Tom reminds us of that, or used to anyway. First of all, it was great to see an adult practitioner. As a pediatrician, we often don't get to interact with our adult colleagues, and I think we often can share and learn much from each other. You did a great job with that, and very nicely applied to the patient. You commented towards the end about statistics and how we tend to apply those and give that information to people. You have an 80% chance of having a good outcome. But statistics apply to masses and not to individuals. The individual has either a 100% chance or a 0% chance ultimately. And that's the hard thing for us to be able to express to our patients.
Yeah, absolutely. And Joanne Lynn in her Fix It paper said, the idea when you talk to people about how to make decisions about what to do, think about pulling stories off a shelf. Let me tell you about this reality. Let me tell you about this reality. Because you're exactly right. People don't experience it as an 80% chance that something happened to it. They experience it as a 100% chance that that reality happened to them. And so I like to think of this idea of pulling different stories off the shelf so that people could understand this is an outcome and this is what it looks like, and imagine how they would react to that outcome and manage it. Yeah, Tom.
I'm going to assume that even in Wisconsin, you're going to have a variety of patients and ethnic groups. We're very sensitive here to how is the patient or the family coming to this endeavor. It's been minor mentioned, but what about this best case, worst case, when your biological knowledge is minimal?
Right.
Or when you come from a culture that this child in your home country would have been put by the river, left, it wouldn't have been an issue at all.
Mm-hmm.
We've had a number of cases that we've presented here. So I'd like that must happen with adults, and that must be a part of your conversation. Could you comment about how the tool is adjusted for those pieces?
Yeah, so this is a tool very much in its infancy. I mean, we've basically used it on 20 patients and actually studied that. I think that if you think through the techniques we currently use, they're not particularly friendly for lots of different people. It requires some real ability with numeracy, and it requires some real ability to take a certain type of information and make a judgment based on that. I would hope that storytelling is a way to access many different people. That's something certainly available in multiple different cultures. But I think there are lots of different ideas about how to do shared decision making for people with different backgrounds, and even thinking through how that background may get better assistance from the physician who can elicit preferences that are potentially based on their cultural background. Because it doesn't necessarily matter where those preferences come from. What matters is an understanding of those preferences enough to make a recommendation that does actually fit within their cultural and teleologic framework about how they think about the world.
I have a question about using the technique. It's a practical question. It seems like most likely, least likely, and the best, worst. You could say, well, the best outcome is something that's only going to happen 1% of the time, and the worst is like, this is horrible, but it probably only happen 1% of the time. So you're kind of targeting the most likely at the 50th percentile. Is the worst going to be at the 75th and the best at the 25th? Just how do you frame that? Because you could really make the best outcome sound really good, because that 1 out of 100 patients might really have a fabulous outcome.
Yeah, I mean, I love this question. Eric Wadera, who's a palliative care doctor at UCSF, he said, is the worst case scenario like when a meteor hits the hospital and we all die? And, I mean, I think that's the issue, right? What are the bookends that you choose? And if you think about a lot of decision aids and tools to support shared decision making, all of that stuff is pre-populated. And it's pre-populated because they want to actually control the doctor, not because they want to necessarily inform the patient quite so precisely, though maybe there's some value in that. The way we conceptualize it is the best and worst of what is realistically possible. And so I think the miracles go above that. Of course, miracles, maybe they exist. I think everybody would hope for a miracle. I think when people say, well, we're hoping for a miracle, you say, yeah, I hope for a miracle too. But the miracle would be above best case, worst case. That's better than this. And I think worst case scenario, yeah, a meteor could hit the hospital. That is possible. But I think that we have all had enough clinical experience, enough to put some bookends on this. I think a lot of why we shudder to provide prognosis and fail to guide people is we're so afraid of being wrong. And I think a lot of my surgeons were like, well, what if the patient does better than best case scenario? And I have to say that the degree to which they do better may be really more subjective than we think. And that by just telling a story that is within the context of what the best case scenario would look like, it's still a lot more information than what we're getting with the way we do it now. And it's a way to set up a decision strategy for people who aren't used to making these high stakes decisions, right? You have to imagine alternative reality, which you have never thought of before, and then think through how that might play out for you. And that's the kind of tough work that needs to get done here that I think even if we don't tell the most precise, accurate, this is the absolute best case scenario, we can still do that work.
I think we're out of time. Please join me in thanking Dr. Jevons.